All right, well, now is about as good of time as any to discuss some of the infectious diseases. Today, we're going to talk about the Epstein-Barr virus, which is the cause of infectious mononucleosis. We're going to talk about CMV, which is cytomegalovirus. We're going to talk about rubella and a little bit about measles. Here we go. All right, so the rubella virus was first isolated in 1962. Acquired rubella is also known as German measles or the 3-day measles. It's caused by an enveloped single-stranded RNA virus of the Togaviridae family. Because the virus is endemic to human beings, the disease is highly contagious and transmitted through respiratory secretions. Before widespread rubella immunization, the viral infection usually occurred in childhood, although it also affected adults. There is a vaccine available. It's known as the MMR, the measles, mumps, and rubella vaccine. Some signs and symptoms would be rash and fatigue. A diagnosis of acquired rubella is not based solely on clinical manifestations. The signs and symptoms of rubella vary widely from person to person and may not be recognized in some cases, especially if the characteristic rash is light or absent and may occur in a substantial number of cases. Rubella infection may also resemble other disorders such as infectious mononucleosis and drug-induced rashes as well. The laboratory testing for rubella would be ELISA for IgM or IgG antibody, or the TORCH antibody testing. And the TORCH antibody testing is a group of tests for infectious microorganisms such as toxoplasmosis, other viruses, that's the O, rubella, cytomegalovirus, and herpes. Those are the tests for the TORCH diseases. Measles is also known as rubeola. Rubella and rubeola are two distinctly different infections. Rubeola is referred to as measles, and measles is a highly contagious disease caused by the rubeola virus. Endemic or sustained measles transmission has not occurred in the United States since the late 1990s. The minimal number of cases yearly in the United States is the result of the high rate of vaccination. Occasional small outbreaks from imported cases of measles primarily infects unvaccinated individuals. So there is a vaccine available, and that vaccine, of course, is the MMR. This is an RNA virus. It is highly contagious, and some signs and symptoms would be things like fever, rash, cough, and malaise. And laboratory testing would be ELISA for antibodies to measles, IgG or IgM antibodies, or viral culture is probably not as quick, but certainly does the job in diagnosing measles. CMV infection is endemic worldwide, with most urban adults demonstrating evidence of infection. 50 to 80% of adults in the United States are infected with CMV by the age of 40. The prevalence of CMV seropositivity increases steadily with age. CMV is found in all geographic and socioeconomic groups, but in general is more widespread in developing countries. Human CMV is classified as a member of the herpes family of viruses, so it is a herpes virus. All the herpes viruses are relatively large enveloped DNA viruses. There is no vaccine for CMV, and the signs and symptoms of CMV would be things like sore throat, fever, swollen glands, and malaise. Laboratory testing for CMV would be things such as viral culture and PCR. The Epstein-Barr virus is widely disseminated. It is estimated that 95% of the world's population is exposed to the virus, which makes Epstein-Barr virus the most common virus known to humans. Epstein-Barr virus is a human herpes DNA virus that infects B lymphocytes. Infectious mononucleosis caused by Epstein-Barr virus is usually described as acute and benign and self-limiting. It's also known as a lymphoproliferative condition. It is a DNA virus, like I said, and some signs and symptoms of infectious mononucleosis would include things like sore throat, fever, fatigue, and rash. Lab testing could be the heterophile antibody testing, and also leukocyte differential should be performed as well, where we're looking for increased atypical lymphocytes. When looking for heterophile antibodies for infectious mononucleosis, we are looking for heterophile antibodies that are composed of a broad class of antibodies. These antibodies are stimulated by one antigen and react with an entirely different and unrelated surface antigen present on the cells from different mammalian species. Heterophile antibodies may be present in normal individuals in low concentrations, but a higher titer is clinically significant in patients with suspected infectious mononucleosis. Now, there are three types of heterophile antibodies. There are Forsman antibodies, serum sickness antibodies, and infectious mononucleosis antibodies. These heterophile antibodies react with other naturally occurring antigens on the cells of sheep or horse red cells. The heterophile test is considered a direct hemagglutination procedure where we have patient heterophile antibodies that bind with naturally occurring antigens on sheep or horse red cells. Heterophile tests have been used for decades, and the rapid tests of today are based on those more complex and antiquated Paul-Banel and Davidson tests. The Paul-Banel test indicates only if heterophile antibodies are present in patient serum, while the Davidson test indicates what type of heterophile antibody is present. So that's heterophile antibody testing, which we do to determine if a patient has infectious mononucleosis.